Thank you for joining our beneficiary educational sessions for the month of May. I'm Dr. Sandra McDonald, and I will be sharing with you some information surrounding NHI this afternoon. Joining me in the on the session is Mrs. Chandra Sawyer and Dr. Nina Graham, who you will hear from later on. We appreciate you taking the time to join us this afternoon and welcome you to the May's beneficiary educational session. As we get started, I'm going to switch my camera so that I can share my presentation and we can move forward. So as we go through the presentation, as Dr. Graham makes a presentation, we're going to, I want you to please put your questions in the chat so that at the end of the presentation, we can draw attention to them, right? Thank you so much. And I appreciate you taking the time to be with us this afternoon. Give me 1 second, let me adjust my screen and I will be ready to go. I'm trying to minimize my screen here. Okay, so again, welcome on behalf of the board of directors and the leadership team here at NHI. It is my pleasure to welcome you to this afternoon session. This afternoon session addresses women's health, and our speaker this afternoon, as I indicated, is Dr. Nina Graham, who you'll be hearing from later on in the program. As always, these sessions are designed with you, the Bahamian public, in mind. And the goal of this afternoon session is to discuss the importance of women's health and the importance of women taking care of themselves and making self-care a priority. But before Dr. Graham begins her discussion this afternoon and making her presentation, I'd like to provide you a brief overview of NHI, who we are, our mission and our vision and our focus, and where we are now, and sharing a little bit about what the future looks like for the authority. So here at the authority, it's our mission and vision to lead the way in providing access to affordable quality care for all Bahamians, and also to transform the current healthcare system, understanding that the future well-being of Bahamians depend on the transformation that the authority will provide. We want to ensure that you, the Bahamian public, are at the center of the care that we're providing, because we know how important quality healthcare is. How do we do this? We do this by being committed to our mission and our vision and focusing on our values. And some of our values are we're passionate about providing universal healthcare to all Bahamians, meaning all Bahamians should have access to quality care. We want to be progressive about the care that we're providing and making sure that we're engaging and utilizing technology to bring about solutions in healthcare as appropriate. We also want to be able to create partnership with the healthcare community and with you, our stakeholders, our beneficiaries, and making sure that we're dedicated to delivering affordable quality healthcare. We also want to make sure that we're demonstrating that the care that we're providing is being offered in with the utmost integrity and honesty, that we're accountable, and that the care we're providing is transparent and with it being done with a certain level of sincerity. We also want to make sure that the care that we're providing is respectful and we're honoring you, our beneficiaries, and ensuring that the care that we're provided meets the needs of the Bahamian public. Our focus as a part of NHI Health and Wellness Program, we're committed to creating platforms to educate Bahamians and make them aware of the things that impact their care, and encourage Bahamians to adopt and embrace healthy lifestyles. Understanding that your lifestyles, the life that you live and the choices that you make as Bahamians will ultimately impact the quality of of life that you have. Whether you make good decisions or poor decisions will determine the outcomes of your health care. We want to make sure that you're integrating exercise regularly into your daily regimen, and that you have an understanding that food is as medicine. We are what we eat. And I know that's difficult for a lot of us to pay attention to, but food should be treated as medicine, and the understanding the importance of having a balanced meal. And like Dr. Graham will talk about this afternoon, the importance of self-care, focusing on mental, emotional, spiritual health, looking at healthcare and taking a holistic approach to healthcare, not just focusing on physical health, but emotional health is important as well. Eliminating stress from your life is critically important to ensure that you have good outcomes. Where are we now at the authority? So for the last 5 years, the National Health Insurance Authority has been in existence. And so over that period of time, we've significantly impacted the quality of care to the Bahamian public. And we're well on the way in terms of transforming healthcare in the country. Some of our milestones over the last 5 years, we've been able to embrace technology to make sure we integrate telehealth in the care that we're providing, so individuals in the Family Islands can have access to care or access to doctors in New Providence. And then we've been able to develop or embrace the technology utilizing the electronic health record, where you as beneficiaries can actually go into the electronic health record. Once you give us your email address, we can make sure that you have access to the patient portal, and that you can actually book your appointments, you can review your labs, you can communicate with your doctor, you can actually get lots of educational materials from the patient portal. And so that's the way we've been able to use technology. I would dare to say that the authority is probably one of the most technologically advanced agencies in the country, and we're pretty happy to share that with you. I'm pretty proud of some of the things that we've been able to accomplish using the technology and taking advantage of technology. We're also rapidly growing. Currently, the authority continues to grow, and we currently have about 120,000 Bahamians enrolled in the program, and we continue to grow on a daily basis. Our demographics, so the persons enrolled in the program, that 120,000 Bahamians that are enrolled in the program, spans across 17 islands, including Grand Bahama, Exuma, Long Island, and as well as Eleuthera, Cat Island, Andros, Abaco, and we continue to expand to our family of islands. Currently, there's probably around 6,000 plus children enrolled in the program, and we're aggressively focusing on enrolling schools and making sure that every child is enrolled in the program. And that's one of our emphasis as we move forward in enrolling. And we also currently have about 15,000 seniors enrolled in the program. So we're rapidly growing, and we'll continue to grow. We've also expanding our network of providers. Currently, we have about 104 physicians enrolled in the program with 57 primary care facilities and 16 labs. Now, our focus also is to bring on diagnostic imaging, which will include mammogram and other type services. And so as the program expands, then the level of care will continue to expand. Some of the other things we're focusing on, you, the Bahamian public, we have been telling us how well we've been performing. Every 2 years, we run a beneficiary satisfaction survey. And in the last beneficiary satisfaction survey, which was done in 2021, 96% of those persons who participated in the survey indicated that they were satisfied with the level of services that we're providing to the Bahamian public. So that gives you a perspective on who we are, some of the things we're doing here at the authority, where we're going, and what we hope to achieve in the future. I'm going to now turn it over to Mrs. Chandra Sawyer, who will introduce our guest speaker for this afternoon. Chandra.
Good evening, everyone. The health of women differs from that of men in many unique ways, and as it is referred to as women's health. According to the National Library of Medicine, women's health refers to the branch of medicine that focuses on the treatment and diagnosis of diseases and conditions that affect a woman's physical and emotional well-being. Women's health includes a wide range of specialties and focus areas. And this evening, Dr. Nina Graham will touch on a few of them. Women represent the cornerstone of a family's overall health. Ensuring that they have access to quality care can also lead to improved health for children and families. The health of families and communities are no doubt tied to the health of women. And the illness or death of a woman has serious and far-reaching consequences for the health of her children, family, and the community. Today's women's health is taking on a higher position in society as people have come to realize that while women have many of the same diseases as men, their symptoms and treatments may not always be identical. According to the World Health Organization, 810 women approximately die every day from preventable causes related to pregnancy and childbirth, and this statistic was provided in 2017. Also in 2017, 295,000 women died as a result of maternal causes. And in 2018, 311,000 women died from cervical cancer. More than 85,000 of these deaths occurred in low and middle income countries. Under the NHI Bahamas program, the primary care benefits offered specifically for women include maternity care, and these include services such as pregnancy tests, prenatal doctor visits, lab tests, screening for genetic characteristics. Women are also able to receive vaccinations and immunizations, particularly the HPV vaccine, and cancer screenings, particularly Pap Smear testing. Dr. Nina Graham, our facilitator for this evening, is a practicing OBGYN specialist. She's a certified forensic gynecologist and a health coach with a passion for women's health, physical, spiritual, sexual, and mental. She loves to educate on all aspects of women's health through individual consultations, public forums, social media and group presentations, awareness campaigns on her website, and through 2 of her successful Facebook groups, which focus specifically on women's health. These groups are Her Evolving Journey and the Menopause Launch. Dr. Nina's philosophy on educating women is this: knowledge opens the eyes, liberates and inspires the mind, and creates a desire for change within. Vanessa Adams stated that wisdom is the ability to act on knowledge. This is Dr. Nina's prayer and hope for the women she encounters daily. Dr. Nina is the founder of Femina, a practice that specializes in women's health and wellness in Nassau. She operates daily from the Femina Clinic located in Palmdale and once a week at the Family Medicine Center on Blake Road. During her spare time, she enjoys taking a dip in our beautiful crystal clear beaches, boating, traveling to exotic destinations, listening to jazz and R&B music, hanging out at her favorite local spots, and simply snuggling up with her son, Israel, in front of the TV. This evening, we want to welcome Dr. Nina Graham as she presents on women's health. Good evening, Dr. Nina.
Good evening, everyone. And thank you for having me present to you ladies this evening. Now, my presentation entitlement given by none other than my soror, Women's Health. Take time to care today. Okay, so the definition of health by WHO is health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Tonight, I will focus more on the physical aspect and talking about risks and risks factors and things along those lines. We'll bring in some of the social well-being, also somewhat mental. So we're going to touch a little bit on the other areas. However, we're going to be focusing mainly on three major health conditions that affect women worldwide and in the Bahamas. Next. Okay, so these are some key factors about women's health. According to WHO, on average, women live longer than men worldwide, about 4 years longer. And the women's life expectancy at birth was found to be more than 80 years. And this was seen from 2011 in 46 countries. Life expectancy is beyond 80 years, but this was not including the African region. Now, globally, the number one killer of women is cardiovascular disease. Yes, it's cardiovascular disease. And following number two, breast, and in terms of cancers, breast cancer, cervical cancer. Now, breast cancer is the leading cancer of killing women worldwide. In the Bahamas, breast cancer is also the number one female cancer. However, cervical cancer, as it was mentioned earlier, is the leading cancer of the female reproductive tract that's killing women in the Bahamas. Next. So in terms of cardiovascular disease, according to Jay Mendoza, research expert, it was found that the most prominent cause of death in the Bahamas as of in 2019 was ischemic heart disease, with close to 86 deaths per 100,000 people. Stroke and hypertensive heart disease were also significant causes in that study of death in the Caribbean, in the Bahamas, with a rate of around 57.5 and 50.8 deaths per 100,000 population. Yes. So let's look at heart disease. Heart disease is the leading cause of death in women, and it is twice as likely, women are twice as likely to die if they have a heart attack than men. Many women, mainly because many women don't recognize that they're having a heart attack or believe that they're having a heart attack. Also, when they, and so of course, women don't go to the emergency room when they have chest pain or, uneasiness, shortness of breath. Some of these things they pass off as nothing. They're not thinking that it's a heart attack. And because of the presentation that women have, and of course, some of us at that age, where we're in that menopausal, perimenopausal stage, there's so many symptoms that kind of sound the same. Perimenopausal symptoms and symptoms of a heart attack, they could present similarly. So in many cases, women don't go to the emergency room because they pass it off as something else. And then for some women, when they do go to the emergency room, of course, they're often misdiagnosed. So in terms of presentation, women present, some of them don't have the typical chest pain. They may have pain in the neck, the jaw, the arm. A heart attack in women may present as a panicky or an easy feeling. Feeling like someone just scared you, or, shortness of breath. Of course, we may pass that off as something else. And general discomfort or tightness in the chest, but not necessarily pain. And this is even so where you present with symptoms in the neck and the arm. That is even more common in women who have coexisting comorbid conditions like diabetes. You may present with sweating or any of these exacerbated, these symptoms can be exacerbated by working out, walking, exertion, or stress. So many women pass off the symptoms, and oftentimes their symptoms are misdiagnosed. Next. So this is a slide. I don't know if you guys can see it very well, but this is a slide comparing the presentation of men versus women when it comes to heart attack symptoms. So again, you may have lightheadedness, again, that I discussed, the neck and jaw pain, upper back pain, and discomfort in the abdomen, feeling of anxiety. All of these things, all of these symptoms you may get in a woman, but you're not going to get the same symptoms in a man. Nausea, vomiting is also a way that women can present with heart attack. Next. So let's look at some of the risk factors. Now, next. Risk factors are often divided into modifiable and non-modifiable risk factors. And when I say modifiable, these are more like lifestyle risk factors versus non-modifiable, which are risk factors that you can't change, like your age. Of course, the risk of heart disease increases with age. And the reason being, in women, we don't have the cardioprotective hormones that we used to have when we were younger. And so prior to menopause or perimenopause, the risk of heart disease in women are less than in men. But as you get around the perimenopausal age or around the 50s, the menopause, basically you don't have the hormones that you normally have, mainly the estrogens and the progesterone. So they are cardioprotective. And so once those hormones are taken away, then the risk of having heart disease and a heart attack becomes higher in women than in men. Gender, we just discussed that. Genetic factors. If you have family members, there may be a genetic condition in the family so that predisposes you to strokes and heart attacks and aortic aneurysms. And so those can run in families. And of course, race and ethnicity. You know that heart disease is more common in the lower socioeconomic groups, and of course it's a fact that the lower socioeconomic groups have more of the Black race or the Hispanic race. So the risk of heart attack is more in that age group, that race, and of course in females. Now, modifiable risk factors. You do know that if you have comorbid conditions such as hypertension and diabetes, then your risk of heart disease is higher. Smoking, of course, smoking we know increases your risk. Obesity, and that has to do with your diet and the fact that you may not exercise, all of these, and physical activities, these are modifiable risk factors. And high blood cholesterol. So you would see that in the modifiable risk factor group, all right, is important, and I'll mention it later on in terms of preventing a heart attack. You should stop smoking. You should be able to monitor your sugar and your blood pressure and your cholesterol levels. And of course, exercise and diet has a lot to do with helping those different areas, helping those areas to be normal blood pressure. You can exercise and help to modify your pressure levels, your sugar levels. Once you start exercising and dieting, eating the right foods, your sugar level becomes normal, and the same with the cholesterol. Next. So the role of the physician in heart disease is, and you're going to see these same sentiments echoing throughout my presentation, but a history is important. Get a history from the patient if they're hypertensive, diabetic, high cholesterol levels. So some of these risk factors we normally pull out in our history. And again, a diet high in carbohydrates and saturated fats, no exercise. So we're pulling out some of the things that we think put you at risk just in our history alone. And again, in the family history, that is so very important to find out if there's a history of heart attacks, angina, anyone in the family had to have a bypass surgery or a stents placed, or if there's a family history of high cholesterol, high blood pressure, diabetes. So family history is very important in your history taking. And then of course, ask the patient about symptoms, if they have any of the following symptoms, not just symptoms related to heart disease, but symptoms related to diabetes, which, the frequency, the polyuria, the polydipsia, increased thirst. For some of my patients, of course, I'm a gynecologist, so I have to put this in there. I have a lot of women come in with recurrent yeast infections. And yeast infections could tell a woman, hey, if they're diabetic, my sugar is not controlled, or if they're not a diagnosed diabetic, then what I tend to do is check to see if they're diabetic. So all of these things you would get in the history, and when you're examining the patient, it is important. It's not just before you even put your hand on a patient. There are certain measurements that can clue you into, hey, maybe this patient is at risk, or maybe this patient is an undiagnosed hypertensive or diabetic. And so you would carry on your examination to look for some of these areas. So you want to look at the patient's BMI. We spoke about obesity, so you need to get a measurement of their height and weight. Their blood pressure, everyone should do a blood pressure when you see a patient. The normal blood pressure is 120/80. The next slide will give you some more about normal blood pressure levels. Your pulse, if your pulse is high, that may tell you that that there's some sort of heart disease going on, even from your pulse. Your urine is very important. Your urine. Urinalysis, looking mainly for proteins or glucose, may give you an indication that, hey, the patient may be hypertensive, or even proteins in the urine may indicate that the patient has early kidney disease or have an infection that can cause them to become, to have kidneys, problems with their kidneys. Glucose in the urine also can give an indication if the patient is a pre-diabetic or diabetic. And of course, you want to do a glucometer reading, mainly if the patient gives a history of being diabetic, because you want to know if they're controlled. And then before then, you look at the patient, you look at their swelling of the legs, you look and see if they're obese. Just as a patient walking, you want to look at everything from head to toe. Are they obese? Is their gait normal? Look at their lips, see if they're smokers. Look at their fingers, see if they're smokers. Discoloration of the ankle will give you a clue if they have peripheral vascular disease. Check the pulses, all the pulses at the wrists, at the feet, at the neck. Check all the pulses. Some doctors will put a stethoscope at the neck to see if you have any blockages in the vessels of the neck. And then you examine the chest. So you're doing all of these things before you even examine the chest itself. And of course, you're looking for things like an enlarged heart, the apex beat or the heartbeat. You're looking at these things. These are important, and this is the role of the physician at your visit in order to exclude or determine if you have any heart disease. Next. Next. Right, and this is the slide about what not the normal blood pressure you should have, 120/80, and then you're looking at hypertensive crisis, 180/120. You have some. They say that hypertension or high blood pressure is the silent killer. Now there are a lot of people walking around with very stage 2 and 3 high blood pressure. And they're heading for strokes. Okay, so it's important to do that blood pressure. Next. And other things that'll occur at your visit is you can't just, a lot of patients think, hey, I just go to the doctor and they examine me and they can find out what's going on. Sometimes it's not obvious. And so that is why we send you for lab investigations that may also give us a clue as to what is going on. And so your lipid profile we're gonna do, we're looking at the cholesterol levels, your triglycerides, and your bad cholesterol, especially your LDL. We're looking at your glucose level. Your hemoglobin A1C gives us an idea of what you're eating and what your sugar control is over a 3-month period. So that hemoglobin A1C is very important, and your renal function. So all of these together will give us an idea of what your risk is of having heart disease or having a heart attack. And of course, if we want more studies or more investigations, we'll do things like an ECG, chest X-ray, and an echocardiogram. Of course, once any of these become abnormal in terms of like your echocardiogram, then we refer to the specialist. Next. All right, so how do we prevent heart disease? And prevention is very important, hence the reason why the annuals and annual physicals are very important. So you want to, again, I mentioned some of these, you want to manage the blood pressure, the blood sugar, the cholesterol. Those are very important. And of course, you want to exercise. It's very important. Even if it's just walking, the sedentary lifestyle really increases your risk. And of course, smoking and alcohol to minimize or stop. Of course, a little wine every now and again is not bad, has been proven to be good for your heart. And try and maintain a good weight. If you do your patient's BMI, you'll be able to tell if the patient is morbidly obese, so you know where to go. Now, to reduce stress, many women we manage our households, we have full-time jobs, we just do everything. And is our stress level, probably not realizing it, but our stress, that can, all of these things, managing the children, some of us go to school at night, everything is just a lot of things that we are into, that we do, our activities, and it could really have an effect on developing heart disease and heart attacks. So reducing stress is very important. Exercise is good for reducing stress. Things like yoga, meditation, and sometimes just taking a break, closing the door, reading a good book, and just doing you helps a lot with stress, with your stress level. So these are some of the steps in order to prevent heart disease. Next. Okay, so let's shift gears to we're going to be talking about female cancers in the next 2 areas. So the first one is breast cancer, next, which is the #1 killer cancer killer in the Bahamas and worldwide. Cancer is the second leading cause of death after heart disease in the Bahamas and women. The top 3 cancers in women in the Bahamas after breast are cervical, uterine, and colorectal cancers. Screening and prevention is very important in reducing the risk of these cancers. Next. So what is breast cancer? Breast cancer is the overgrowth of breast cells to form a mass, which is either felt as a lump or seen on mammogram or ultrasound. The tumor is said to be cancerous if the cells spread locally to surrounding tissues or distally or distant to areas of the body, such as the brain, and that's according to the American Cancer Society. Next. So, what are some of your risk factors? Again, there are modifiable and non-modifiable risk factors. And some of the modifiable risk factors, similar to heart disease, these are, being a woman is a non-modifiable. Age is non-modifiable. Late menopause is non-modifiable. Family history, dense breast tissue, genetic, having the BRCA1 and 2 genes, these are non-modifiable. And some ethnicities and previous breast cancer, these are non-modifiable risks. Now, the modifiable risks, like heart disease, are basically somewhat the same in terms of reducing your alcohol intake, no smoking, or reducing the amount of cigarettes you smoke, a healthy weight, and any stress, eating well, okay? These are some of the modifiable risks. If you're obese, if you eat mainly fast foods, if you drink alcohol, any of these things will increase your risk for breast cancer. Now, a few other things, if you have had a long time that you were on any hormones, that can increase your risk, and that's a modifiable risk factor. And of course, breastfeeding, all right, is also a modifiable risk factor. Next. So 60 to 70% of patients with breast cancer, patients without known risk factors, 60 to 70% of them have breast cancer. And 30 to 40% of patients with known risk factors have breast cancer. So what this means is that the majority of patients present with breast cancer and they don't have any risk factors. Okay. And this is why I teach a lot of women to do self-breast exams. Do self-breast exams because they may not have the risk factors, but they may, if they do their self-exams just before the periods every month, they may be able to detect a lump in the breast. All right. And also I teach them to check the axilla because you may have a lump in the axilla with no lump in the breast. So it is important as a physician to teach women how to do self-breast exams. Next. So the role of the physician is to identify, again, risk factors in the history and counsel the patient on ways to reduce those risks, and examine the patient for breast masses and teach the patient how to do self-breast exams. Encourage the patient to do regular checkups annual checkups and to do regular screening during those annual checkups, such as the mammogram, or in women with dense breast ultrasounds. But mammograms from the age of 40 and of course 35, less than 40 or 35 years, if there is a family history, a strong family history of breast cancer. Now, some of the other symptoms or signs that a woman would get if they have breast cancer, besides a breast mass, not every woman presents with a breast mass, but they may have a nipple discharge, an abnormal nipple discharge. It may be bloody, it may be green, it may be yellow, all right? Breast swelling or dimpling of the breast, or something called port orange. Basically, it looks like the peel of an orange, the outside. And that's how some women's breasts look who have breast cancer. Or if there's a strong family history of breast cancer, you can refer to the oncologist for gene testing. Next. All right, now moving on, we're looking at cervical cancer, my baby. Cervical cancer is the growth of abnormal cells in the lining of the cervix. The most common cervical cancer is squamous cell carcinoma, accounting for about more than 70% of cases. Adenocarcinoma is less common, about 25% of the cases, and are more difficult to diagnose because it starts higher up. It is cervical cancer is the only cancer that has an excellent screening test, and it is absolutely preventable. Next. Next. Okay, so basically we're looking at what is cervical cancer. Now, how cervical cancer may begin is from precancer cells or dysplasia, which is shown on the slide here. Sorry, it's a little blurry. But basically, the basement membrane, if you see that long red horizontal line, that's your basement membrane. And below that are the squamous cells, or the normal cells that line the cervix. So you may go from a mild dysplasia, which will account for about 1/3 of the cells are abnormal, to severe dysplasia, which is about 2/3 or the full thickness of these cells on the bottom part of the horizontal line are abnormal. And you will see things like this on your Pap smear, which is your ideal screening test. Your Pap smear may say L-cil, which is the second is mild dysplasia. All right, or it may say H-cil. So it's basically saying a high-grade lesion or a low-grade lesion. Now, the basement membrane, which is that horizontal line of cells, if a high-grade dysplasia is left for about 5 years or more without any treatment, the abnormal cells burst, as you can see, through that basement membrane or that horizontal line into the bloodstream, and that is the definition of cervical cancer. Next. Okay, so what causes cervical cancer? Cervical cancer is caused by a virus called the human papillomavirus. It is a sexually transmitted infection, and it accounts for about 90+% of all cases of cervical cancer. And the human papillomavirus has many subtypes. The more common ones are the types 16 and 18. Those are the cancer causing, but they do have other subtypes that are also cancer causing, but the 16 and 18 is the more common subtypes. And the non-cancer causing subtypes of HPV are 6 and 11. Okay, they are more the cause of genital warts. Okay, so 16 and 18, and this is actually the what they use to create the vaccine, which is a very important primary preventative measure that we use to prevent cervical cancer. So the vaccine, the original vaccine, Gardasil, is a quadrivalent vaccine that has these 4 subtypes, 6, 11, 16, and 18. However, recently, over the last decade or more, 20, 30 years, they have come up with Gardasil 9. And the Gardasil 9 basically gives you an extra 5 subtypes, cancer-causing subtypes that are in that particular vaccine. So it gives you an extended coverage. All right, so it is prevention. I'll discuss it a little, well, I'll mention it a little later in the next slide, in a couple slides. Next. So I don't know if we have any men in the audience, but a lot of you may feel as though the human papillomavirus, because we always hear about cervical cancer, we feel as though that's the only area that the human papillomavirus attacks. Nope, no, it doesn't. So it also attacks the vulva, the vagina, all right, and for men, the anus, for both, and for men, it also can attack the penis, the anus, and for both of us, the throat. As a matter of fact, back in the day, throat cancer or oropharyngeal cancers were mainly due to smoking, but it has been reported that a majority of the cases of oropharyngeal cancers now, first of all, they're increasing, and they're due to the human papillomavirus. Okay, so that vaccine is very important in preventing or prevention. Next. So how do women present with cervical cancer? So basically, it depends on the stage. But before we do that, some women with early stage cervical cancer may only present with bleeding. Okay, they may only present with bleeding. Now, women, it is important to note, and I'll plug in here with some of the other cancers. All of the cancers of the female reproductive tract presents with bleeding, whether it's with abnormal bleeding, whether it's your normal menses become heavier, which we call menorrhagia, or you bleed between the periods, intermenstrual bleeding, or you bleed after sex, or your normal days of bleeding extend. So let's say you normally bleed for 5 days, you end up bleeding for 2 weeks. Women who have stopped having their menses may start to bleed, and no, it's not okay. It seems to be a myth in our society. Women think that they can be young again by bleeding after they go through menopause. No, that is abnormal. Okay, so a lot of women, there's this thing where they feel as though it's normal for you to bleed after you go through menopause. No. And so and bleeding, just so you would know, apart from bleeding being a symptom and a sign of cancers of the female reproductive tract, malignant cancers, but you also have bleeding for benign cancers of the womb, or you may have abnormal bleeding with an ovarian cyst. So it is very important for we as physicians to investigate the patient to find out what the cause of the bleeding. And myself, as a OBGYN and working in the area of gyne-oncology in the public sector, the first thing I want to do is rule out cancer. I'm not worried about you bleeding from your fibroids. I'm not worried about you bleeding from your hormonal imbalance. I'm more concerned that you're bleeding and I need to exclude cancers. So so when you have early stage disease, you present with bleeding. Some women present with an abnormal discharge. They will give the story that they went from physician to physician and they're diagnosed with a yeast infection or some other infection that has a discharge, and there are a myriad of infections. But and then so you have to know that, hey, if I'm continuously treating this lady for a yeast infection, then let me go a little further. Okay. If a woman comes with bleeding, besides the cervix, I'm going to sample her uterus, her womb. I need to find out if it's not a cancer in the womb. I'm going to do an ultrasound. I want to look at to see if she has fibroids, exclude that, or look at the ovaries. Any of those can present with bleeding. And so, of course, as you become more late stage 2 and 3, okay, in cervical cancer, the symptoms are no longer, I mean, you can still have bleeding, but you have other symptoms, such as some women go into renal failure, so they give symptoms of uremia, and women have a lot of pain and bone pain and that type of thing. So that's more advanced disease. Next. Okay, and this is a slide again looking at the symptoms of cervical cancer. Next. Next. Okay, so let's look at some of the risk factors of cervical cancer. Next. Now, usually if a lady comes into my clinic or my office, I do elicit from the history, again, elicit from the history some of these risk factors. And I usually ask, when did you first start having sex? So your age of koitaki, we call it, or the age of your first sexual encounter is very important. So if your sexual career started at 14, then you would have a longer time period that you could have been exposed to the human papillomavirus. Then if you have a history of multiple partners, if you have, now mind you, I had a lady that came in and she had an abnormal Pap Smear, and they really made her feel like, oh, she runs around. It's not about that, because you can contract the human papillomavirus from your first sexual encounter. So even though we ask about sexual partners, you can still get it with one partner, or you can get it with multiple partners. It's just that your risk is higher with multiple partners. If your parity or the amount of children you have, and that is important in the history, because well, for persons who use condoms, condoms are important to prevent against sexually transmitted infections. So if you're having a child, of course, you're not going to be using condoms. So that makes your risk higher. Smoking increases your risk. And the family history. Now, about 90% of cases, cervical cancer is caused by a virus, a sexually transmitted infection. However, a very small amount of patients may develop cervical cancer from a drug that used to be given to women back in the day. So when you have patients and the women, they have a family history, their sisters, their mom, all of them had cervical cancer, chances are they used D-stilbestrol, which was a medication used back in the day to prevent preterm labor. So that is also increases your risk of cervical cancer. Next. An ounce of prevention is worth a pound of cure. That is so true. Next. Now, the role of the physician is first primary prevention. And that involves basically your Pap test, which you would do during your annuals, and your vaccines. Okay, so usually, apart from a patient coming with a Pap test, if it is abnormal, or even if it isn't abnormal, I always suggest that they get the vaccination. Now, secondary prevention, basically, if a patient comes with an abnormal Pap smear, she has a colposcopy, is biopsied, and it's confirmed, then basically the whole point of the screening test is to treat so it doesn't go to cervical cancer. So if a patient comes with an abnormal Pap smear, then the way to prevent cervical cancer is we basically excise the abnormal cells. And you can do that either by a leak procedure where you laser off the abnormal cells, cold coagulation, which is a misnomer. We're basically heating off the abnormal cells, and a cone biopsy where you basically cut out the abnormal cells in the shape of a cone. Also, it is important that the physician educate the patient on how to reduce her risk factors, the use of condoms with high-risk sexual behavior, HPV exposure, and other sexually transmitted infections is important. So we need to use the condoms if you're not planning a family. And of course, to stop smoking, which is also, again, these are modifiable risk factors. So these are things that we could do something about. Of course, age and family history, you can't change that. Cervical cancer isn't, however, more of a dietary or dietary risk factor in that. Now, mind you, if you do have cervical cancer, certain clean eating will obviously be a plus, but it's not one of the big influencers of cancer, such like breast. Okay, and then the physician also needs to refer the patient in a timely manner to the specialist. We're all physicians, but to the specialist, the gynae oncologist, to manage the cervical cancer, whether it's by radiation, chemotherapy, or surgery, whichever one. But it's important for the physician to identify the risks to try to prevent cervical cancer. And if we do not succeed in preventing it, to direct them into the right channels to get management and treatment. Next. So why screen, when to screen? So we screen basically to diagnose before symptoms develop. It is easier to treat early disease. Now, we basically screen, we take the opportunity to screen to either prevent disease or to treat early disease by doing our annual checkups. Next. So these are some of the essential screening tests that we use. I'm sure there are more, but again, we spoke about blood pressure measurements, glucose testings. Again, you're looking at any risks of heart disease. BMI, looking at your weight and height measurements. Your urinalysis can give a lot of information. Glucose to see if you're diabetic, pre-diabetic. Proteins in the urine, looking at any kidney disease. And ketones also, we get those in diabetics. And basically blood, leukocytes or nitrites, again, may point us towards any type of infection. Now, I'm not going to go over colorectal cancers, but screening just with a stool or cold blood, if you have a family history or you present with features suggestive that you may have colorectal or colon cancer, then the stool or cold blood is very important. And basically, just a general examination. Does the patient look pale? Is she bleeding so much? Her heavy periods that she looks pale. Look at her hands, look at her eyes. Then you basically, along with the eyes, you're looking to see, you know, their little lipid masses that you can see on the eyes that can give you an indication. You can examine the eyes. Diabetics and hypertensive tell a story behind their eyes. So that can tell you if the patient is controlled or if they're heading towards glaucoma or any of those diseases behind the eyes that are associated with high blood pressure and diabetes. You want to do your breast exams, you want to do your thyroid exam. And then you just before you want to check all your pulses, see if the rhythm of your heart is normal. Or is it skipping a beat? Is it too slow? All right, these are some of the things you look at. You look at your legs, look for peripheral vascular disease, look for swelling that may be a sign of congestive cardiac failure. And there's a lot of things that you can find out just by looking at our patients. And again, through all of that, abdominal exam, you're trying to palpate for masses and anything that may be arising out of the pelvis that's large enough, you'll be able to palpate from the abdomen. And again, your pelvic exam, your Pap test. These are all things in the examination that you would do for screening for different cancers or hypertensive heart disease or diabetes. Again, blood investigations. A lot of us have our annuals and we go to the doctor and they do all of those things. And then the doctor gives you a paper and says, okay, I need you to do some blood investigations. And a lot of us don't do it, you know, or we don't do it right away. So the examination and everything gives us one clue, but you need to follow up with your blood investigations. And for women, again, the lipid profile, looking at your cholesterol levels is important, and it'll help decipher if you're heading towards hypertension or heart disease, okay? And it may clue us in to say, hey, you need to change your diet. Your hemoglobin A1C, renal functions, all of these are important for women to determine for heart disease or any diabetes. Now, there are other blood investigations that we may want to do and during the annual, because as women get older, we get thyroid problems, we have hormonal imbalances. So you may want to order some hormonal studies. It depends on how the patient presents, but these are the blood investigations listed here and your complete blood count are essential screening tests. And then of course you want to do your mammogram, again, looking for breast, any lesions, breast cancer. And for women, a lot of women, physicians may not include this test, but it is very important as you get older to do a bone density, because of your bones become osteoporotic with age, and therefore you're at risk of other diseases, not really what I spoke about, but other diseases or falls and fractures that can occur because of a reduced bone density. And of course, mentioning that one of the other top cancers is colorectal cancer. In addition to do your stool or cord blood, it is important to get a colonoscopy at least after 50, at least once or twice to see if you have any polyps or any masses in the colon. Next. So in summary, again, we can go back to the definition of what health is according to the World Health Organization. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Women must put themselves first. We must put ourselves first, and because in order for us to take care of everybody else and do all the things we do on a daily basis, we need to put ourselves and our health first. See about all aspects of our health by doing your annual checkups. We find ways to, we find monies to do all sorts of other things, our hair, our nails, and we leave our health out of the way. But I encourage you and I challenge you, women, to pick a month. If it's your birth month, or if it's another month. January is Cervical Cancer Awareness Month, and I do a campaign every January. Okay. October is Breast Cancer Month. I do my mammogram in that month. And I do try to do all of my annual investigations and stuff in my birth month. So you pick a time and ensure, I challenge you to try and do your annual checkups. The physician has a role to play also, as we need to do complete screening and investigations. But women, we have a role to play too. We have to make that first step and go and seek our physicians to do our annuals, and the physicians, we will do our part. Prevention is better than cure, and early detection has a better prognosis. Next. Thank you. Any questions? Comments?
All right. Well, thank you everyone for taking the time to spend the afternoon with us. Thank you, Dr. Graham. We appreciate your presentation. If this presentation will be posted on our YouTube page, so if you want to share it with your colleagues, family, friends, be sure to do so. And if there are no questions, Chandra, you can proceed with the your final wrap-up comments.
I did get about 3 questions that I wanted to share with Dr. Graham. Dr. Graham, the first question, during your presentation, you had mentioned blood testing and blood screenings as a form of diagnosing diseases amongst women. I know you focused on blood testing for heart, glucose, kidney, and hormonal challenges. Are there any blood tests that are related or specific to cervical cancer screenings?
No, well, no, not for cervical cancer. There is a blood test that we use for uterine as a baseline. It's called the CA-125. And for breast cancer, they have like CA-19.9 and different tumor markers. But other than that, there's none really for cervical cancer. The main screening method for cervical cancer is the Pap Smear.
Okay, and then for the Pap Smear, I know you mentioned about completing that screening with your annual physical, which should be once a year. Is once a year sufficient time frame for testing, or how often should a Pap Smear be completed?
Okay, In the United States, they test with the thin prep, with the HPV testing, they do it every 3 years. Okay, so there is room for that, but I don't do that here, mainly because sometimes you get a patient this year and you don't see them no more. So I tend to do the patients whenever I come in contact with them. For persons who have had abnormal Pap smears before, like if they had just done a colposcopy or a treatment, they may actually be required to do their Pap smears twice a year. So it depends. If I have a patient who from the island and I don't see them, then every time they come up, I'm going to do a Pap smear on them. If I have a patient that comes and does their annuals religiously every year and their Pap smears come out normal, then I may think about doing it every other year or 3 years. I can do the HPV testing for 3 years. So for me, it depends. But basically, in the oncology clinic, we do annual Pap smears. Dr. Butler, my boss, and Dr. Halliday, we always say anytime you can get the patient in, get a Pap smear.
Okay, thank you for that, because I think I've also heard before about the frequency of Pap smears being relative to an individual's diagnosis, like if they have cervical cancer, like you've stated. The final question, is there an age recommendation for when a woman should begin Pap smear tests?
Yes. So we begin at 21, and the age that you can stop, providing that you didn't have any abnormal PAPs within 5 years, is 65. Okay, back in the day, they used to say once you're sexually active, you start doing your Pap smears, or at the age of 18, but they no longer use those recommendations. And it's now the age of 21.
Okay, thank you for providing us with that update.
Mm-hmm.
And I didn't see any other questions come in for the evening. And so again, thank you, Dr. Nina, for your information that we provided to us this evening.
You're welcome. Thank you for having me again.
Always a pleasure. And so as Dr. McDonald would have alluded to, we just wanted to remind our audience about some wellness opportunities that we have in store for you and that have been offered on an ongoing basis. Every third Thursday, we offer a complimentary Power Hour fitness session. So stay tuned for our session for June. And these sessions are led by a certified fitness instructor, and it is aimed for the entire family. So it is for persons of all ages and of all fitness levels. So let's make it a family fun event. These beneficiary educational sessions, similar to tonight, is hosted on a monthly basis. And so we use these opportunities to not only present on wellness sessions, wellness topics, but also to keep you informed as to the benefits afforded to our Bahamians and residents at large about the NHI Bahamas program. And then thirdly, our wellness newsletter. And so if you're not on our mailing list, and if you are a beneficiary and you have not been receiving our quarterly newsletters, feel free to reach out to us, and I will place our contact information. You can reach out to us via email, social media, telephone, as well as visiting our website to get more information as to how you can stay in touch and in tune with us on the wellness initiatives that we are offering free to the Bahamian public. And so once again, we would like to thank you for taking time out of your busy schedule to sit back, to listen, and to receive some piece of education on how you can improve your health and how you can take care of your health moving forward as women. And so we thank you. And we look forward to seeing you to our June installment of our beneficiary educational session. Have a great evening, everyone.
Chandra, just before we wrap up, just want to encourage those of you who are not members of the authorities program, primary healthcare program, to please sign up. Like Chandra said, you can call us, or you can sign up on our website. The phone number is noted on the screen. It's 396-8500. So you can call the authority to sign up to become a member of NHI. It's free to all Bahamians. And if you have relatives and friends or colleagues that are not signed up at NHI, please encourage them to call the authority, go to the website, or stop by. We do curbside sign up, and we're usually open from 9 to about 4 o'clock in the afternoon. So at any point in time, you drop by the authority. We're located on East Street South in the Teachers and Salary Credit Union Complex, or you can call us at any time to sign up. So again, like Chandra indicated, we thank you for your time this afternoon, and please go out and share what you've learned this afternoon. Again, this will be posted on our YouTube page, so you're welcome to share it or tag somebody to listen to it. All right, have a wonderful afternoon, and thank you all for joining us. We look forward to seeing you the next time around. Take care.